Hi, friends. Welcome back to another episode of Your Age is Not Your Cage with Carla Allen. Okay, today we have on a guest that is going to share so much just crucial, imperative information for us on gut health, digestive health, labs for women. It is going to be packed with good information. So let me tell you about my guest today. Her name is Dr. Mary Pardee, and she is a naturopathic medical doctor and also a certified functional medicine doctor. She specializes in integrative approach to gut health and longevity in Los Angeles, California. Dr. Mary is the founder of Modrn Med, which is a medical practice that provides medical and health services to patients via in-person consults, but also as well as telemedicine. She also created a gut health course that dives into most of the common gut-related complaints. So today we will be talking things gut-related, microbiome, comprehensive stool testing, lab tests, bloating, gut-brain connection, all those things. So you are going to love Dr. Mary, and I can't wait for you to hear her. So let's get her on right away, and let's go ahead and welcome Dr. Mary Pardee. Okay, so let's welcome Dr. Mary Pardee to the podcast. Welcome.
Thank you, Carla. Nice to be here.
Yes, I'm so excited and honored to have you here today. I have followed along on the things that you put up on Instagram and listened to you on other podcasts, and I knew that my listeners would love you too. So I wanted to get you on, but before we dig deep, and I want to get right into everything. But before we do, just give us a little history on you, kind of your background, and what led you to where you are today.
Yeah. I'll try to give you the Cliff Notes version of it. But I basically started on this path as a kid that had a lot of GI issues. So I had constipation, bloating, reflux were kind of my first symptoms, and they really started to bother me. So I started to see different doctors, went through the conventional workup, and never felt like I got a good solution to help me feel better. And in my late teens and then into my 20s, I started to see, alternative practitioners and saw acupuncturists and, went to naturopathic doctors and functional medicine doctors and really tried to figure out my own health issues. And still didn't feel well, to the point where I decided to go to naturopathic medical school. I had worked with a naturopathic doctor and just really appreciated her bedside manner and kind of how she went about things. And went to ND school, went through the program, still didn't feel better. And and so I really did all of the things to start to become the doctor that I wish I had had growing up. And I'm at the point where I really feel confident in my ability to help people with chronic GI issues, as well as people who just want to stay well and increase their health span and lifespan. And through the whole process, I was able to get myself out of chronic GI issues. So right now, I don't experience any more than the average person, and I feel really good. And my hope is to help empower, especially women going through chronic GI issues, but just people in general, and what that looks like. Because I remember leaving a doctor's office in tears after he told me, like, there's no solutions to this. You've tried everything. We put you on every medication. There are no answers. And it was because I was looking in the wrong places. But also, I was really disheartened that nobody during my journey had told me potential right places to start looking. And so that's really what I'm offering my patients at this point.
And I can so relate because I grew up with the same type thing and going to different doctors and constant GI issues with no answers other than an IBS diagnosis. But nothing along the way helped. And that did not come until later in life when I started learning and researching and taking different courses and doing things like you. But I also have such a respect for the naturopathic doctors because when my son was young, he had a lot of issues we went every medical route possible, could not find out what was going on and causing him so much distress. And after a long journey, ended up at a naturopath, and that's where we found answers and found healing for him. So I just really admire, what you're doing too. So thank you for that.
Appreciate that. Really appreciate that.
Yeah. But okay, before we really get into all the gut and all those issues, I would love to take you down the path right now of labs and what importance of labs, where you stand on labs, what labs that you recommend and normally request for your patients, because it is a question that I get so often, and I think it's just such a confusing issue for so many people. So I think it could be really helpful if you just lead us through a little bit of that.
Yeah, absolutely. And so do we want to talk about women kind of specifically or just in general?
I have some guys that listen to me too, but I would say specifically my clients are women and most of my listeners. So
okay, so let's stay more women centric, but this is going to apply to both men and women. And so one of the big things that I advocate for is early DEXA scans in women and in men too. More commonly earlier in women, just because of estrogen drops around menopause. And the rates for osteoporosis are higher in women. And I advocate for earlier than this typical standard of care because I have screened many, many women in their 30s and 40s who already have osteopenia or osteoporosis. And the earlier that we can identify that and treat that, the better, because when I'm assessing somebody from a preventative medicine lens, sounds morbid, but I'm really saying, what are the most likely things to kill you? And we have to put hip fracture into that pool, because death from a hip fracture, or the likelihood of dying within 1 to 3 years after a hip fracture, increases as we age. Mm-hmm. And we want to say, how can we prevent that from ever happening in the first place? And that's to have good bone density at a young age to ensure that it's going to still be good in our 70s, 80s, and 90s. And so, especially if you have been underweight for a portion of your life, that's going to increase your risk for osteoporosis. If you've had an eating disorder at any point in your life as well, previous fractures, if you've had any of those, if you've been on things like prednisone or glucocorticoids for, say, you have inflammatory bowel disease or anything like that, these are all things that can increase the risk for osteoporosis and osteopenia. And so I advocate for both the bone density scans for certain women, but also the body composition scans are really, really helpful. And that's for all people, men and women. And the reason we do those, and I think that they should be part of primary care, is it gives us an idea of how much muscle somebody has on their body versus how much fat. And in that group of fat, what percentage of that fat is subcutaneous, which is more aesthetic, like we don't really care about it as much when it comes to our actual health, versus visceral adipose tissue. And that visceral adipose tissue is beneath the fascia, near the vital organs, so around your heart, your liver, your kidney, your spleen. And that is the fat that increases the risk for cardiovascular disease. It has a really strong positive correlation with blood pressure, triglyceride levels, LDL cholesterol levels, insulin resistance, I should say. And so we know that visceral adipose tissue is something that we want to keep below a certain level depending on somebody's age. And so you can see, like, this body composition piece gives us so much more information than what's the weight on the scale, which is what your conventional doctor will just write down your weight, your height, and then they'll calculate something called your BMI, which can either be an okay measure of how things are going or a really poor one, depending on your body composition.
I have had the DEXA scans, and I want to point out too that they're not an expensive test. When I've had them done, I want to say I paid $50. So it's really, really a good test. And I got to see everything that you're talking about. It really helped me see where I was at. And thankfully, I was very pleasantly surprised with where I stood. So that was good news too.
Yeah, and sometimes that's all it is, right? It's just reassurance of like, okay,
Right,
I'm doing it all right. Like,
right.
great. Let me recheck in 1 to 2 years to make sure I'm still doing it all right. And what I end up calculating from that report that's not usually on it is something called appendicular lean mass index or your fat-free mass index. And what that is it's similar to BMI in that it's taking how tall are you and how much muscle do you have on your body and a ratio of those two things. And we know from the normative data what people who are your age and your sex, kind of what the averages are. And so we pin you against the normative data to say, okay, are you in the 50th percentile, meaning 50% of women your age have more muscle and 50% have less? And we really try to get people well above the 50th percentile because when you look at aging and aging gracefully, we want you to end at the end of your life with enough muscle to do all the things that you want to do in life.
Mhm.
And so we almost have to kind of reverse engineer that and say, okay, if we know that you're going to lose muscle as you age, it's almost inevitable. How much muscle do you need to have now in your 40s to be at a good place when you're at 85 or 90? And so that's one of the big things that I'm looking at is somebody well muscled or under muscled? And then I'm looking at, are they normal body fat or over fat? And so those are kind of two things that I'm looking for because we have something called normal weight obesity, which in my mind is an epidemic in the United States right now, meaning normal body weight, but high body fat percentage. Some people will call it skinny fat.
Right.
Um, Increases the risk for metabolic syndrome, cardiovascular disease, all sorts of things related to chronic illness. And so that's one thing that I'm really screening for is, do things look good under the hood?
Right. And so you take these scans and then put them hand in hand with lab work, blood, in addition to that. Okay.
Yep,
Okay. So
exactly.
let's talk about those.
Yeah. So lab work wise, we run really comprehensive, full preventative medicine labs. So your conventional doctor will run like a CBC that looks at white blood cells. They'll maybe run a lipid panel. Some will run vitamin D, not all the time, and they'll usually run a TSH and maybe a metabolic panel as well to look at your liver. Um, in addition to all of those, we're going to run advanced cardiac markers at Modrn Med. So we're looking at things like apolipoprotein B, which is going to be a marker for atherosclerosis, which is the plaque formation in the arterial walls. ApoB is one of those players that you kind of need it around to form plaque in the arteries. And so getting it below a certain level can really help reduce the risk for ASCVD. Similarly, LP little a is another one. It's much more genetically related, but it can tell us if somebody's at increased risk for plaque formation. And then we're going to do a full metabolic suite. So we're looking at fasting insulin levels, A1C, which is a typical test for a lot of primary cares to run to look at your average blood sugar levels over the last few months. And then a lot of the times we're also going to do an oral glucose tolerance test as a screener for people. And what that is you go into the lab, you're fasted, you drink a solution that has a certain amount of sugar in it, and then they draw your blood a couple times afterwards at certain time periods, and we're able to see both your response in terms of what your blood sugar does, but then there's another test that you can order that looks at your insulin's response to that sugar.
Mm.
And with those two things, we can see early stages of insulin resistance before it would be seen on a fasting insulin and before it would be seen on an A1C level. So we're looking at like pre-diabetes kind of thing.
Yeah, which is important. My dad had diabetes, so I'm very familiar with that process. And those are definitely numbers that I watch and look for on everything, that I do when I go in for labs. And so what about as far as female health, hormones, thyroid, things like that?
Yep, full thyroid panel for all of our patients. We'll screen for antibodies to the thyroid as well to see if there's anything called Hashimoto's or other thyroid conditions. So typical, if you go to see your primary care, they'll just run a TSH. We're going to run free thyroid hormones, antibodies, as well as a TSH to get a full picture of what's going on there. And then in terms of sex hormones, the conversation gets a little bit more complicated with women. With all people, we're running testosterone, free testosterone, SHBG, because that's not going to change too much throughout a woman's cycle. And so that's a given, no matter if you're a man or woman, premenopausal, postmenopausal, doesn't matter. With the sex hormones, it really depends on the age of the person coming in. So we want to do an example. It also depends on if they're presenting with any symptoms. So if you're a 25-year-old female who has normal cycles, no symptoms, I'm actually not going to run hormones on you when it comes to estrogen, progesterone, FSH, LH, just because a woman's cycle, when she's cycling, pre-menopausal years, the hormones are going all over the place. And so even if we know when we're testing it at a certain time, it's not necessarily helpful unless there's also symptoms accompanying it.
Okay. For someone that is, say, in their 40s and above, they're perimenopause or postmenopause, is it the same labs or do you ask for extra things?
Yeah, so if somebody is coming to me, 40-year-old woman, common thing she'll say is, I have no sex drive anymore. I'm experiencing a little bit of vaginal dryness, or I have joint pain, or my sleep is not what it used to be. Then very common for me to run estradiol day 3 to 5 of her cycle, day 1 being the first day of bleeding, and then as well as FSH, LH at that time, and then testosterone as well. We run for everybody no matter what. And that the reason for that is we can really start to see where are you in that perimenopausal kind of transition. FSH will rise and estrogen will start to go down during perimenopause into menopause. And depending on what those come back at, we can say, okay, you're actually very close, it looks like. Your FSH is very high. Or, yeah, this doesn't look like what's going on. Maybe we should look somewhere else. And we do a lot of hormone replacement therapy in the perimenopause, menopause, because we see such a drastic improvement in quality of life. I mean, women, it's not uncommon for women to come back after hormone replacement therapy and say, my life is different now. Like, my sex life is back. Like, I haven't had this much sex since I was a high schooler. I heard somebody say, or college kid or whatever it is.
Yeah.
And that's just like a wonderful thing to be able to help somebody with. So those are some of my favorite.
I can tell you that I am on HRT, and it made just all the difference in my world, because I literally thought I was going crazy, and I could not, had no handle on my hormones, or just the sweats, and not just night sweats. I just felt like all I did was sweat, and it was just so great to get so many different things in my body. I felt like leveled out and where they're supposed to be. And I'm a firm believer in HRT for sure.
Yeah, it's wonderful to see. And even things I think the common things are hot flashes and night sweats that people will say, and libido. But it even can be things like joint pain or fatigue or insomnia that just started. Things can be not suspected of hormones that are actually hormonal.
Yes, I had vertigo really bad, and that lasted for quite a while. And that was one of the worst symptoms that I had, but I had never heard of that before.
Absolutely.
But okay, anything else you want to add to that before we move on to more gut digestive type health?
Yeah, a couple other ones that your primary care probably won't run that I like to run. One of them is homocysteine. So homocysteine is a measure of methylation, which is a really fancy word just to say that you're adding a group that has a carbon and some hydrogens on it to something to turn things on in the body, turn them off. It regulates certain pathways as well. Methylation does. And the reason I run this one is there's decent data. One of the studies was called the VitaCog study. It was smaller. It was around 300 people, and they had mild cognitive impairment. They were over the age of 70. And what that study found was that using a B complex that had methylation support in it, what it was able to do is it reduced brain atrophy and improved cognitive function in those individuals when you got your homocysteine to start to lower if it was above a certain level. And so if it's out of range in my patients, I will treat it to below that level that they found in the study to potentially help to reduce that risk. And I do say potentially just because it's not one of those things that's like a home run that we know, but there's enough evidence in my mind to warrant doing that. So that's one of those things. I also run ApoE as an elephant on people. I do talk to them about what it is first to get their consent to run it. When you have an ApoE4 allele, it can increase the risk for Alzheimer's disease. And that's really the key there. It can increase the risk. It doesn't determine if you get Alzheimer's.
Right.
So it's not a gene of determinism. It is a gene that increases risk. And so the reason I like to run it is that it can start to help us to say, what are the things that we really want to make sure are in place if you do come back positive? And we want to keep a closer eye on things like insulin and making sure you don't become pre-diabetic, making sure your lipids in good ranges too, that you don't have too high of levels of ApoE, to make sure we're doing heart scans and catching atherosclerosis earlier. All the things that we know, sleep, exercise, of course, like all of the things that reduce the risk for dementia as we age are really important. And then I do omega-3 indexes on a lot of my patients, and vitamin D, B12, magnesium, kind of these tests as well. That's a general overview of what the blood work would look like.
That's great. And I've had the ApoE test because my dad did have vascular dementia and Alzheimer's. And I wish I had known so much of this information when he was diagnosed early on, because I just didn't have this information available. So I'm just so thankful that it's out there to help people now and going forward, because it's so important to know these things and how you can, that it's not a death sentence, and for me, mine was very low risk. But people that are just knowing, but you don't have to accept that this is the route you're going.
For sure, for sure. And I'm one of those people. I'm an ApoE4 carrier. I have one copy, one allele. And my grandfather had Alzheimer's. And so but it's not something that scares me. It's more like, okay, I got to stay on. I'm not going to stop exercising. I'm not going to, let my insulin levels start to rise. I'm going to make sure everything stays on track.
Right. Okay, so let's move over to more of the gut digestive health. And I want to ask you about, since we're on testing, certain testing for that and your thoughts on, I know when we go to a regular medical practitioner, a lot of times there's stool tests or microbiome testing, or I would love to hear your thoughts on these. Are these useful tests, not useful, and the tests that you recommend if it's not those?
Yeah, this is probably one of the more controversial things that I talk about, and it's all over my Instagram too. So go check it out. But that's because I'm a naturopathic doctor and I don't recommend microbiome testing. And a lot of functional medicine naturopathic doctors do a lot of that. And I will be the first to admit that I have ordered them in the past. And we call medicine a practice because it's just that. We learn and we make changes and we improve upon. And so at this point, I really believe that microbiome tests are a complete waste of money at our current stage in where we are in medicine and research. And so I think that there's going to be a time where they will be useful, and we just don't have the technology to make them useful right now. And I can give an example of that and just interrupt me if I'm going down a rabbit hole, but these tests, when you're looking at them, that functional medicine doctors will run, they're giving you a handful of bacteria that they're looking at. So they'll say, there's this much of this bug and this much of this bug, and you have quote unquote dysbiosis. However, what's going on there is that they're cherry picking a bunch of random bacteria and saying, these are the ones that we want to look at. And when you talk about bacteria, you have to get to a place where you're talking so specifically that you're naming the strain of the bacteria. And if you remember back in biology class, we talk about taxonomic levels. And so you have your kingdom that includes bacteria and archaea. And then under that, you have a phylum. And let's take E. coli for an example. That would be Proteobacter for E. coli. And then getting more specific, in that Proteobacter phylum, we have different genuses. And so the genus for E. coli is Escherichiae. That's the E part of E. coli. Within that genus of Escherichiae, we then have species. So then we have Escherichiae coli. Even within that species of E. coli, we have different strains of E. coli. So we have E. coli 0157H7. That's the E. coli that causes foodborne illness diarrhea, traveler's diarrhea. We don't like that one. That one's not fun.
Yeah.
It's no good.
Yeah.
But then in that same species of E. coli, you also have a strain called E. coli Nissl 1917, which is used as a probiotic that can help with constipation. It can help with inflammatory bowel disease. It has beneficial properties for humans. Now, these stool tests that you're looking at are oftentimes stopping at the genus level, which is 3 above where we just left off. So that's stopping at Escherichiae. It's saying how much Escherichiae is there in your intestinal tract. And you can tell that we still haven't differentiated the good guys from the bad guys if that's where we're stopping. And that's a huge issue with these companies, is that they're using ones that you've heard of, where you're like, oh yeah, that's not a good one. I've heard of that one. But even if we talk about streptococcus, okay? And so streptococcus kind of sounds bad, right? Strep we associate with group A strep that can cause strep throat as well as other things. But then you also have Streptococcus salivarius, which is the same genus of Streptococcus, but it's a different species. And Streptococcus salivarius has a ton of beneficial properties at reducing inflammation, reducing NF-kappa beta levels. And so it's not the end of the story if you're just talking at the genus level, is what I'm getting at. And so I just don't think that they're useful. I can keep going on this. There's several other reasons, but even if we just stop there alone, it can start to make sense as to why, yeah, these could be good if we eventually get to the level where we can start to identify the strains. But we're not there yet. We just don't have the technology to be able to say, okay, this is exactly who's there and this is who should be there. Because our gut microbiomes are as different between all of us as our thumbprints are. And I never would say, you know, Carla, your thumbprint's wrong, mine's right. Our thumbprints are just different, and that's where we're at with the microbiome. There's a lot of different ones that look like they're probably healthy. And until we start to decide and figure out from research as to what will denote a healthy microbiome versus an unhealthy one, these are useless to us because we don't have that information yet.
Right. Well, and that makes sense. So what are the tests that are useful that you will run on your patients to help with this diagnosis?
Yeah, great question. And so I do believe that some stool tests are helpful because you can look at E. coli 0157H7 if somebody comes in with diarrhea. You can look at Giardia in the stool. You can look at calprotectin levels in the stool to see, is there inflammation that's present? And so I still use stool tests, but I'm looking at very specific things to eliminate certain diagnoses for people versus some of the more expensive functional medicine tests that are cherry picking and doing all the stuff that I mentioned. And then you have other tests for the GI tract too. So if somebody comes in, we may do some of those stool tests that I just mentioned that are validated and have good evidence behind them. We'll also do blood work. Very likely we may do something called a lactulose breath test that looks for an imbalance of bacteria in the small intestines that could indicate small intestinal bacterial overgrowth. So there's a whole slew of tests that you can still do to form a diagnosis, but we really want to make sure at Modrn Med, this is where the name actually comes from, is that we're using modern medicine that is evidence-based and validated so that we know that the results are actually going to give us something that we can take action on.
Right. So what about things then like bloating, constipation? Are these similar type tests or is it completely different? What do people do for that and how do you treat that? Because there's so much out there for all of that. And I would almost add acid reflux in there to see your thoughts on that, because those seem to be such common things. And it seems to be that so many people think being bloated, or it will go with bloated, that it's normal. Like after you eat, it's just kind of normal. I get bloated or even constipated. I'm constipated for 3 days, but that's just my body. So what's your thoughts on all that and treating that and What do you normally recommend in that case?
Yeah, good question. It's a tough one to answer because every person is going to be different. So you can
Right.
have two people who are constipated and you may actually run different tests on them depending on the symptoms. Um, And so when somebody comes in with constipation, it's very common for us to run a SIBO breath test as well as to do blood work because you want to look at thyroid potential issues with the thyroid gland. And then there's other specialty tests that we will sometimes run, and that's very patient dependent to look for things of, do you have an issue with actually the mechanical part of having a bowel movement? And so in order to have a bowel movement, you need to relax certain muscles and contract certain muscles in the pelvic area. And there's a lot of people that have discoordination of those muscles, and there's actual tests that you can do to look at something like that. So that's another piece of information, but you don't run all the tests on everybody. It's very dependent on when somebody comes in. They may say, I go to the bathroom, but I don't feel like I fully went to the bathroom. And that's different than somebody who's just having little rabbit pellets.
Right. And I thought of a question in that. Let me think real quick. Oh, I know. When you talked about the thyroid and constipation, like I don't think anyone puts that together. How does that go hand in hand?
Yeah, so if your thyroid is not working well, then what happens in the GI tract is the GI tract has multiple inputs to it to regulate motility, which is movement of the GI tract. And one of those inputs is thyroid hormone. And so you need thyroid hormone to make sure you have normal motility of the intestinal tract. And if you have low thyroid hormone, it can slow motility. So constipation is a very common sign of hypothyroidism. And it's a very simple blood test to run to say, okay, that is the cause, or nope, that's not the cause. And on the flip side, somebody with diarrhea, you can see that sometimes in people with Graves' disease or hyperthyroidism too.
Okay.
So it's an important one to rule out for people.
And then back to also acid reflux, because so many people just pop the over-the-counter, the Pepcid and Tums. And my dad used to walk around with either Rolaids or Tums in his pocket and was constantly popping them. And I know that is such a thing, just to grab the Pepcid AC after you eat and for acid reflux. What are alternatives, and what do you usually do in the cases with people with acid reflux?
Yeah, so we want to see the full picture. For instance, you can have somebody with small intestinal bacterial overgrowth that also has acid reflux. And so if it's due to poor motility or an overgrowth of that bacteria, then you may see improvements when you actually treat the bacterial overgrowth. You can have reflux that is caused or exacerbated by stress and anxiety. So I've had individuals where the only thing I did is treat their anxiety and the reflux went away. And then you can have a totally different archetype of somebody with reflux who is 50 pounds overweight, has a beer belly, is not exercising. And where I would start with that person would be weight loss, because any sort of increase in intra-abdominal pressure, which can be from fat, increases the likelihood of reflux to happen. That's why you see reflux increase during pregnancy, but also just people who are overweight. And so you can see with those three examples, the treatment's different for all three, but you're still getting rid of the reflux. So it's very dependent on the person, what the most likely cause is when they're coming in. And sometimes it's not that obvious too.
Yeah.
And those can be tougher cases.
Yeah, I'm pretty confident that most people probably are not relating anxiety or stress to, certain symptoms like acid reflux. And so that leads me into my next question, in kind of the whole gut-brain connection and our mindset, and how our thoughts, our behaviors, the things we're doing, how do those affect the whole GI tract and all of these things that we're discussing?
Yeah, and I like that we're here now because it kind of ties together the beginning where I said those weren't my issues. This was my issue. So when I talk to people, I'm like, there's a whole pie. If we look at the possibilities of contributing factors, it's a whole pie chart. There's little slices, meaning, yeah, a little bit could be diet, could be exercise, could be stress, lifestyle things. It could be the mind-body connection. It likely isn't just one of those things. Most of chronic issues are multifactorial. And so it's identifying what slices are your issue and how are you going to go about treating them. And for me, I have really focused on what supplement am I not taking? What deficiency do I have? Do I have an overgrowth of bacteria? I was just so focused on the physical pieces of it. I did not look at all at that mind-body piece. I didn't really know how to look at that piece, to be honest. I didn't have any guidance for it. And to be fair, the field of gastroenterology wasn't where it is at today, too. So we didn't just know a lot of it as well. But the gut-brain interaction is well respected and established in the gastro community at this point. Even conventional medical doctors have heard of it and understand it. A lot of them don't know what to do to treat it, but it's gotten to the point where we've actually renamed a class of disorders that used to be called functional GI issues to now they're under the umbrella term of disorders of the gut-brain interaction, or DGBIs. And this is really exciting because we're starting to understand just how important this gut-brain interaction is. And how I explain it to people is that you have a highway that runs from your gut to your brain, and it's bi-directional. Cars are going both ways. So your brain is sending information down to your gut, and your gut is sending information up to your brain. And when somebody has a disorder of the gut-brain interaction, there's a kink in communication that is happening on that highway. So information is no longer freely flowing both ways. And another good analogy is the tire pressure in your car. So most of us have like a little thing that will light up to say, okay, you have low tire pressure and you need to go fill up the air in your tires. But that gauge can actually break, and it's one of the most common things to break on a car. And it doesn't always mean that you have low tire pressure. It could be a broken receptor. It's the sensor that's actually broken. Similarly, in DGBIs, we can get miscommunication from the sensors in our gut, and it starts to send the wrong information up to the brain. So it's sending information of we're uncomfortable, we're in pain, we're bloated, we're distended, something is wrong. And that gets registered in the brain. And our most common reaction to that is frustration, fear, anxiety, just what's going on. This is a new symptom that I've had. And then when we have those symptoms, which again are normal responses, our innate kind of programming tells us pay more attention to those symptoms to figure out what's going on and to try to help it. So we start to focus on the bloating, the pain, the discomfort. The hyper focus on the symptom increases the perception of the symptom in the brain. Yeah. So your brain then goes, oh, she's focusing a lot on that. It could be killing me. That's what it always thinks, is maybe I'm dying or something's really wrong here. I'm going to focus more on it and increase the pain. The pain increases and we start to develop coping mechanisms, which again are very normal, but that's things like, okay, now I'm going to look in the mirror and I'm going to see, am I bloated? Is my stomach sticking out? I'm going to start touching my stomach to see if it feels hard, to see where the pain is. I'm going to change my diet. I'm going to start to exercise differently. I'm going to take foods out. I'm going to take gluten out. I'm going to take dairy out. I'm going to take eggs out. I'm going to take nightshades out. Okay, somebody told me that all vegetables are bad. I'm going to go carnivore, right? And so we start to do these things to help our symptoms, and these are called coping mechanisms. And a lot of the times, these coping mechanisms can actually make things worse versus better, because it is sending more signals to our brain that something is wrong, something is wrong, something is wrong. She keeps trying to fix it. That means something is really wrong. And then the cycle starts all over and gets worse and worse and worse and worse. And this is really the IBS stress cycle, but it can happen in many different conditions where the original kind of change you're trying to make is to help the symptoms, and it actually ends up worsening the symptoms.
And I mean, that just makes so much sense, because I can see where that cycle just continues to go on and on and on. So how do you get out of that cycle?
Yeah, great question. That's what everyone asks. Like, well, you know what?
Yeah.
So now we have tools to be able to help people, and the different tools are one, addressing the thoughts and beliefs that you have around your symptoms and to identify the actual cause. And so this is where diagnosis is actually really important, is that a diagnosis of IBS is not a diagnosis of exclusion, meaning that a diagnosis of IBS tells us this is a disorder of the gut-brain interaction, and it's not a pathology that is harmful to your health. If we don't even know the diagnosis, then we have to step back and start to say, okay, do we think that this is a disorder of the gut-brain interaction, or do we think it's a pathology that's organic, like Crohn's disease or ulcerative colitis? And you have to make those differentiations in the beginning to make sure that you're treating the person effectively. But once we have a diagnosis and we know it is this disorder of the gut-brain interaction, it is IBS or it is functional bloating or something like that, then we want to start to identify the thoughts that are perpetuating the symptoms and making it worse and start to change those thoughts. Same with behaviors. What behaviors are we doing right now that we think are helping that could be hurting? And how do we change those behaviors to be more effective in healing? There's things like hypnotherapy that's actually been studied to improve these symptoms as well. And then we use something called cognitive behavioral therapy with people. And the most common thing I get is, so you're saying it's all in my head then? Like you're saying I'm crazy, like you're saying I'm anxious,
Yeah.
you're saying, and there is truth in that. People with IBS are more likely to have anxiety than the general population that doesn't have IBS. However, there's a group of people with IBS that don't have a diagnosable psychiatric condition like anxiety or depression. Even if you don't have a diagnosis of anxiety and depression, we're still going to do these things because we know in the research we get improvement of symptoms. And so this is not treating anxiety. It's not treating depression. It's just treating that tunnel, that highway that's going from the gut to the brain to make it so we don't have that kink in communication anymore. So things are more accurately being tracked back and forth.
It's just the confirmation of how powerful the brain is and what we think and what we tell it. And that's just a confirmation of it. And I'm sure so many people probably are not connecting that thought pattern and exactly what it's doing to their system and their body after time after time after time. And just for me suffering with IBS as a young girl, I'm sure because I always waited for something to happen. I was continual. I was figuring out what was I going to do if I had an episode, and it just was such a stressful time of just that whole mindset wrapped around, okay, I got to figure out how I'm going to handle this. And yeah, I had no answers back then on what to do. And so it was hard. Yeah.
It's really, really hard. And the last thing we want to do is gaslight people and say, you just got to change your thoughts too.
Yeah.
It's very, very hard. And many people will come to me and say, well, I'm stressed because I have to run to the bathroom, or I'm stressed because I can't go to the bathroom. I'm stressed because I'm bloated.
Right.
And what I tell those people is, and that makes total sense. And 99% of the population would have the same emotional response that you're having. And to treat it, we need to come at both places. So we need to still treat the thoughts, the behaviors that are perpetuating it. And we still need to treat, like if you're having diarrhea, there's supplements and medications that we can use to heal that too. But what you don't want to do, which I did for over 20 years, is just focus on the physical piece of it. Hope that the mental, emotional piece will get better. When you target both of those at the same time, people get better much, much, much faster.
That's so good. As we wrap up, so I want everyone to know a little more. I gave the brief introduction about Modrn Meds. Will you share about what you do, and are you able to help? I'm pretty sure everybody online or in person. Does it matter where you're licensed? I know that's a question a lot too.
Yeah, great question. So Modrn Med is a virtual telehealth company. So we see people who are located in many different places. In order for us to be your doctor, you need to be located in a place that we are licensed in. And so some of those states are going to be California, Colorado, Arizona, Vermont, Connecticut, we're adding Massachusetts very soon, so maybe when this comes out, that one, but just check to see if we're licensed in your state is the first thing. We do some health coaching with out-of-state clients. It looks very different than how we work with established patients though. But I have a team of doctors who, some of which have actually had GI issues themselves, and we're really devoted to really holistic care. And when I say that, I think unfortunately, functional medicine has sometimes gone down a path of just replacing medications with supplements. And we're really wanting people to choose therapies that are proven to be effective, have evidence to support them, as well as testing similarly, like we talked about today. And so we're pretty different than a lot of functional medicine practices in that regard. And we're really just determined to help people that have chronic GI issues, as well as people that, are looking for hormone replacement therapy, going through menopause. And Dr. Sheeler and Dr. Williams are wonderful. I send my family to them and are very trusted sources in my book.
Okay, that's wonderful. Now tell our listeners where they can find you. Where are you most readily available?
Yeah, so I do a good amount on Instagram. I'm at dr.marypardee for my Instagram. I do some reels. I talk about parasite cleanses, whether I like them or not, poop stuff, longevity stuff. We have an Instagram for Modrn Med. It's at Modrn, MODRN-MED. And we also have a website and a newsletter where we send out tons of free information, interviews all about constipation, bloating, heart disease risk factors, all of that. And that's at our website, modrnmed.com. And again, it's MODRNMED.com.
Well, and I'll also have all that in the show notes, so it'll be there for everyone to be able to find you easily. But I have enjoyed this so much, and it's just there's so much that we could talk about, so much more, I realize. So I know we just hit the tip of the iceberg, but I believe that you provided good information that will help our listeners kind of get some direction and know which way to go, which way is right for them. So I just appreciate you so much and your time and coming on here to just help and to encourage and to inform. I really appreciate it.
Carla, thank you. And thank you for spreading the word. I really appreciate all that you're doing for everybody. It's really, really important.
Absolutely. It's something that is such a passion of mine. And I just want to get information and options out there for people so they know that they're not stuck. This is not where they have to stay. And I think, from learning about you, you're just such another option for people that it feels right for. So I'm just thankful that I found you. So thank you for taking the time and for being here.
Thank you. Appreciate it.
And I just want to tell everyone, just remember, Your Age is Not Your Cage comes out every Wednesday. And don't forget to share this with friends, family, everyone that needs to hear this. I know everyone out there probably knows someone that would love to have this information. So share and go on and check out her website and Instagram. But until next week, thank you for joining me. I love y'all. See you soon.